let's now go to the relations. What's the relations of the joint? The relations of the joint. Okay. Um, I think I'm gonna finish with this one. Let us go to the nerve supply. All right. I remember say he mentioned what you call Newton's law. It's don't be worried. It's nothing much. It's nothing much. The Newton's law, it says that the nerve supplying the joint, nerves supplying the joint, supply the muscle moving the joint, and the skin covering the incision of these muscles. So if you're going to have a joint, you don't know the nerves that are going to supply the joint, but you know the muscles that attaches the joint, or sort of like, you're getting it right. So you can now detect the nerves, right, from the muscles, right. So a nerve supplying the joint will supply the muscles moving the joint. Simple as that. So um, we see that our joint, our hip joint, we are going to have muscles of the anterior compartment that are going to have action on the hip joint. Muscles like what? We have the rectus femoris. The rectus femoris, mind you, is the only muscle of the quadricep that crosses two joints. It crosses one, the hip joint. It also crosses the knee joint. This rectus femoris, we say that it originates from the anterior inferior iliac spine, and then it crosses the hip joint, crosses the knee joint. So which means that if it crosses the hip joint, which means it's a nerve that supplies it also supplies the joint. You're getting it right? So that's why we have the femoral nerve over there. Yeah. We also have the anterior division of the obturator nerve. The obturator nerve, the nerve of the medial compartment of the thigh. The nerve of the quadratus longus, quadratus brevis, adductor magnus, the gracilis, all those things, except the hamstring portion of the adductor magnus that is supplied by the what? By the tibial nerve. Is it? Now, we go to so we have the femoral nerve, the anterior division of the obturator nerve, the nerve to the rectus femoris, the nerve to the quadratus femoris, the sciatic nerve, the inferior gluteal, all those nerves that supply that joint from the Newton's law. They will supply the what? That supply the muscle, they will supply the joint. Are we together? Are we together? And mind you, we have nerves. For example, we have nerves that supply both the hip joint as well as the knee. So, for example, we have the posterior branch of the obturator nerve. Are we still together, guys? We have the posterior branch of the obturator nerve. It supplies the knee as well as the hip joint. So, pain of the hip joint can as well be transferred to the knee. Is it? So that one, you need to take note of that one. All right, so let's move. Where am I? Okay. All right, so this is our nerve supply. And also take note of this. The femoral nerve is the main nerve that supplies the hip joint. And the femoral nerve is, if there is a hip disease or a dislocation on the hip, we are also going to affect the anterior all right, how can I say it? The anterior and the medial portion of the thigh cutaneously. Because you remember the femoral nerve, it is going to send those the intermediate cutaneous nerve as well as the medial cutaneous nerve. So these nerves, if there is a dislocation of the hip, they can also affect the femoral nerve, and also you can have pain being sent to the anterior portion of the thigh as well as the medial portion of the thigh. All right, you're good to go. Now we are now going to the blood supply of the hip joint. Blood supply of the hip joint. This is very important. You need to take note of this one. All right, so let me just start by just going. Okay, here's my time. All right, so I'll try to be fast as possible. Right, so we're going to have what you call a femoral. Let me just rush to it. Rush. Okay, where is my femoral? Right, okay, so Right, so as you can see here, this is your, yeah, your descending aorta, blah, 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 bifurcate, blah, blah, blah. Right, and then we're going to have into internal and external iliac artery. The external iliac artery behind, when it just passes the inguinal ligament, it will become the femoral artery. The femoral artery now, it enters the femoral triangle. Yeah, I think yesterday we mentioned about the femoral triangle. So before I explain the blood supply, let me just run through the course here. Not everything, but just a bit. So this is your femoral artery. It's gonna send posterolaterally here. I don't know if it's clear. It's gonna give what you call the profunda femoris artery, or the deep artery of the thigh. So if you see it here as the deep artery of the thigh, it's just the profunda femoris artery. You mustn't be confused. So this one, it is given posterolaterally. You can see. So the deep artery of the thigh is gonna give two branches. Bear with me. Two branches superiorly, and then inferiorly as it descends, right? It will descend at the undercover of the adductor longus, so the adductor magnus, right? As it will be descending like this, it will send the perforating branches. So there are three perforating branches: first perforating branch, second perforating branch, third perforating branch. Then it will terminate by itself being the fourth perforating branch. We'll talk about this maybe other time. But we are mainly fascinated by this anastomosis, right? So if you can follow my case here, this is your profunda femoris artery. It's gonna give two branches superiorly. This one being the lateral circumflex femoral artery. This one, the lateral femoral circumflex artery, it will give three branches. Let's go. It will give an ascending branch, which is called an ascending branch of the lateral circumflex femoral artery. You see here. It's going to give a transverse branch of the lateral circumflex femoral artery. You see here. And then it's going to give a descending branch. They have a name here. But this descending branch is going to take part in the anastomosis around the knee. We're going to talk about it. So we also have some blood supply coming from the lateral femoral artery. This lateral femoral artery, in terms of relation to the femoral nerve, it's very important because it divides the anterior and the posterior branches of the femoral nerve. So when the femoral nerve enters the inguinal, below the inguinal canal, inguinal ligament, it will be outside the synovial sheath. It's going to split into anterior and posterior. And those anterior and posterior, they are going to be separated by the lateral circumflex femoral artery. Are we together? Now, let's go. So, the medial circumflex femoral artery, you can see it is just posterior there. But if you can take note of my case. So, this one is going to send a transverse artery, a transverse branch of the medial circumflex artery, and an ascending branch. So let me talk about the cruciate anastomosis and the trochanteric anastomosis. So at the medial border, at the medial of the greater trochanter, you're going to have a depression that is called the trochanteric fossa. The impression of the trochanteric fossa, that's where we have the attachment of those muscles, the superior gemellus, the obturator internus, the inferior gemellus, they are attached here. But in that fossa, we're going to have an important anastomosis. Take note of this. This anastomosis is made by four arteries. One, the lateral circumflex, the ascending branch of the lateral circumflex artery. Two, the ascending branch of the medial circumflex artery. This medial circumflex artery will give a certain branch, like we've said. And then the descending branches of the inferior gluteal artery, superior gluteal artery, forming this trochanteric anastomosis, which is a rich anastomosis that supplies which is the major blood supply to the head of the femur. Very important. So among all these anastomosis, right? These arteries anastomosing here. Take note that the medial circumflex. I think I've said much. Let me go to a simplified diagram. If I don't know, if is everyone able to see here? Right. So this is your medial circumflex femoral artery. So the medial circumflex artery sends about 90% of blood to the head of the femur. I'm gonna tell you the reason why. Why not the lateral? Why not the lateral? Okay. Remember, the lateral it's ascending here. This will be your lateral, right? Take note of this. This will be your lateral. And what is on the anterior aspect of the capsule? The iliofemoral ligament, which we said what is the strongest ligament in the body. So which means this strongest ligament of the body is going to be difficult for the lateral ascending branch of the lateral circumflex artery to penetrate and send branches to the head of the femur. So therefore the medial circumflex femoral artery will send branches, more branches than the lateral. Are we together? I hope I'm not rushing much. All right, good. All right. Amazing. So let's continue. I don't want to bore you guys. We just want to be done with this. All right. So that was your trochanteric anastomosis 4. Undertone 1. Tadichi. The ascending branch of the medial circumflex femoral artery. 2. Tadichi. Ascending branch of the lateral circumflex femoral artery. 3. Tadichi. Descending branch of the inferior gluteal artery. 4. Tadichi. The inferior branch of the superior gluteal artery. That's your trochanteric anastomosis. And then, remember, we said we have subcapital fractures. So if I am going to draw a fracture here, that will be a subcapital fracture. And these fractures, they are more prone to women that are in the post-menopause phase of life. Because remember, in post-menopause, estrogen levels, they decrease, and estrogen is very important for bone forming, bone resorption, whatever. And if you are now in the menopause phase, you are going to have low estrogen, and therefore you're going to have osteoporosis. And osteoporosis just means that the bone is going to be eaten up. So fractures like this, they happen mainly in old women that are above the age of 50. And such fractures, they result in a vascular necrosis. So let's now take note of this. So this is your artery of the ligament, the artery of the ligament teres, right? This artery, where can I start? Okay, this artery in young people, remember we have what we call an epiphyseal plate, right? So in young people, there's a prominent epiphyseal plate because the bone is still growing. So in young children, there is no anastomosis between the artery of the ligamentum teres and the retinacular artery of the medial and the lateral, whatever, from the trochanteric anastomosis. Why? Because there will be closure of the epiphyseal plate. But as you grow, there will be the epiphyseal plate is going to close. So therefore, we are going to have fibers of this muscle. So you're going to have arteries supplying the head of the femur. So as you increase in age, the artery of the ligamentum teres, it becomes insignificant. So therefore, it insignificantly supplies the head of the femur. Is it? Insignificant supplies the head of the femur. So if there is subcapital fracture, there is a vascular necrosis. There will no longer be blood being supplied to the head of the femur. Okay, I think I've said that much. Now let's go to the cruciate anastomosis. So the cruciate anastomosis is also formed by 4 arteries. So remember, let me go to my, I have to be fast here. Right, so if you remember, this is my profound femoris artery transverse. So we said the lateral circumflex femoral artery give the transverse, as well as the medial give the transverse. Those transverse will form the what? The cruciate anastomosis. So cruciate anastomosis is formed by 4 arteries. Let's go. 1, the transverse branch of the lateral circumflex femoral artery. 2. The transverse branch of the medial circumflex femoral artery. 3. The descending branch of the inferior, not the superior, of the inferior gluteal artery. 4. The ascending branch. You see this ascending branch? They haven't name, but this one, this is where you have the first perforating artery. This will be your ascending branch here. So it will form also the cruciate anastomosis. Where is the cruciate anastomosis found? At the middle aspect of the lesser trochanter. At the middle aspect of the lesser trochanter. And these anastomosis, they are very important because they facilitate anastomosis between, or blood communication between the iliac artery, the internal iliac artery, and the femoral artery. Because we have branches from the femoral artery and some branches coming from the internal iliac artery. For example, the superior and the inferior. So it facilitates communication of those arteries. Whew. Yeah. Pakashata. Any question about blood supply? Anyone with a question about blood supply? Yes. Hello?
So, like the dislocation of the femur from the acetabulum causes avascular necrosis.
Come again?
Does the dislocation of the femur from the acetabulum cause avascular necrosis?
Dislocation of the femur.
Yeah.
All right. On the dislocation of the femur, we have to mainly, we're not talking about dislocation of the femur, the anterior dislocation and the posterior dislocation, right? And the posterior dislocation, mainly, we are not causing fractures of the neck. Avascular necrosis is prone when we have fractures of the neck, because fractures of the neck, that's where we have the main blood supply. You're getting it? So at the posterior dislocation, we are not affecting the neck. We may affect the artery of the head of the femur, right? But it's insignificant. So dislocation of the femur.
Thank you.
You're getting it? Okay. Thank you so much for the question. So we proceed.
Thank you.
All right, amazing. We proceed. Okay, so let's go, guys. Let's go. I think by F7 I should be done. All right. Okay. Where was I? So I was done with the blood supply of the femur. Okay, let me go to my slide and see what else left. Okay. So now let us go to the action. We go to the action, right? Of the what? Of the joints. Right. So I'll just use here. Let me go to the muscles. Can you unmute, please? Can you unmute? Thank you so much. Thank you so much. Okay. Yeah, maybe I'll use this one. All right, so let's go to the actions of the hip joint. So we have a flexion, right? Flexion, extension, adduction, abduction, lateral rotation, medial rotation. Those are 6 actions. So actions, they are very easy because you need to understand the insertion and the origin of the muscles. When you understand the insertion of the origin of the muscle, you just know that the muscle or the joint is going to move towards the origin of the muscle. Very simple. All right. So let's start with the flexion of the hip joint. So flexion of the hip joint, we're going to have the iliopsoas muscle. So this is your psoas. This is your iliac muscle. This is your psoas muscle, right? So this one, they facilitate flexion. We have the pectineus. It also facilitates flexion. Pectineus, it has 2 actions: flexion and abduction. Take note of that. Flexion and abduction. And then we have, remember, we said those 2 long muscles that crosses the hip joint as well as the knee joint. What are those? this one, the sartorius muscle, that is 40 centimeters long approximately. It's a strap bent muscle. Yes, 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 yes. So it crosses this joint. It also crosses this joint. So here it have actions like one. I'm just going to mention them. The sartorius one. We're going to have flexion of the thigh. Two, lateral rotation of the thigh. Then three, abduction, not adduction, abduction of the thigh. So in a five more actions, and per hip joint, unit three. And then if it goes to the knee, tiazotaura, it attaches. It's a part of the pes antennas, right? And then it facilitates the medial rotation of the knee as well as what? Flexion of the knee. Yeah. So flexors one, the iliopsoas, the rectus femoris, the sartorius, as well as, yeah, Snell says some portion of the adductor muscles, right? Including that the pecneus, like we have said, the pecneus facilitating the flexion. We are done with the flexion. We go to the extension of the hip joint. So I think I need a lateral view. Let me see if I can get a lateral view. Right, this is amazing. Can this do? All right, take this one. Okay. Now, so extension of the hip joint. Extension of the hip joint is made by muscles of the hamstring compartment. Muscles of the hamstring compartment. They are flexors of the knee joint as well as they are extensors of the hip joint. Hamstring muscles. Except, not all of them. Mind you, not all of them. Except the short head of the bicep femoris. Because the bicep femoris short head does not cross, NB does not cross the hip joint. It doesn't cross the hip joint. It only crosses the knee joint and the facilitated lateral rotation of the knee. You're getting it right? So the hamstring, the hamstring compartment, that's the semimembranosus, the long head of the bicep. Is it? As well as the ischial portion of the adductor magnus, that one, that the hamstring portion. We also have, this is very important, take note of this now. This is your gluteus maximus. Your gluteus maximus is two insections. The first insection, which is the main insection, is at the iliotibial tract. Remember the fascia lata, it thickens laterally, forming the iliotibial band of the iliotibial tract. And the 3 of 4 of the gluteus maximus attaches the iliotibial tract. 1/3 attaches the gluteal tuberosity. Mind, very important. The part that attaches to the iliotibial tract is responsible, NB is responsible for extension of the hip joint as well as extension of the knee joint via the iliotibial tract. The portion that attaches the gluteal tuberosity. If you have to look at the femur, let me rush. Here, this is your femur. You're going to find that go a gluteal tuberosity, which is the origin of the lateral lip of, is the lateral lip of the linea aspera. So remember the linea aspera, they diverge proximally and distally. So the lateral lip of the linea aspera is the one that thickens upon the gluteal tuberosity, which attaches the 1/3 of the gluteus maximus. And this portion is responsible for lateral rotation of the hip joint. So I'm done with the extensors. Let me go to the NB. Take note of this. The extensor group is powerful than the flexor group. The extensor group is powerful than the flexor group. So those muscles that extend, they are more powerful than those that flexes. Yeah, I think that one is noted. All right, so let's go to adduction. Adduction is very easy. If you have understood your thigh, you are going to understand that we have the medial compartment. The medial compartment, that's where we have the adductors. So we have the adductor brevis, the adductor longus, the adductor magnus, and the depicting us, like I said, it is a flex as well as an adductor as well. Then we are done about that one. Um, and then go to abduction. Let me see if I can see here. I've said much. Abduction here. So abduction. So you're going to find that the gluteus medius, it will attach to the lateral portion of the what greater trochanter, and the gluteus minimus, the anterior portion, the greater trochanter. When these muscles contract, they will pull the joint. They will pull the bone here, causing abduction. Abduction, right? And it's also facilitated. You see, this is the piriformis muscle coming from the internal surface of the sacrum, greater sciatic, whatever. It inserts at the apex of the greater trochanter. So when it inserts at the apex of the greater trochanter, when it pulls, it's going to cause abduction. Right. I think I've mentioned that one. Very important. Now let's go to the medial rotation. Medial rotation. What we have a medial rotation. Okay, medial rotation. So medial rotation, these muscles that we have already said, the gluteus minimus and the gluteus maximus, they also facilitate medial rotation, as well as the tensor fascia lata. The tensor fascia lata, to those that are not aware, this is your tensor fascia lata. It originates at the tuberosity of the iliac crest, and then it inserts on the iliotuberal tract, and then via the iliotuberal tract, it causes extension of the knee, assisting the gluteus maximus. That's the tensor fascia lata. Good to go. Now we go to the lateral compartment. So, oh my God, the lateral rotation. The lateral rotation is very easy. You see these muscles that attach to the posterior aspect of the greater trochanter. These are the muscles that are responsible for the lateral rotation. Right? One, what do we have? We have this one, the superior gemellus. The superior gemellus originating from the ischial spine, attaching with the tendon of the obturator internus. By my impression is the trochanteric fossa, which is the greater trochanter. Yes, and then we have the obturator internus as well as the glomerulus inferior. These muscles as well as the quadratus femoris. When they contract, what do? They cause what? They cause a lateral rotation. These are very important muscles because that's where the sciatic nerve sits. That's where the sciatic nerve sits. Is it? Amazing. Right, so another important here note is that the lateral rotators, they are powerful than the medial rotator. So the extensor group, powerful than the flexor group. Lateral rotators, powerful than the medial rotators. Yeah, I think I've said much. Let me see what I am left with. But I'm almost done. I just have to do some few clinicals, and then we are done with the hip joint, and then we can take the knee joint. But don't worry, by half 7 I'll be done, so that we also have another segment later. Okay. Now, so let's go to the clinicals. What are important clinicals that you need to take note on the hip joint? All right, I didn't have a slide here, but I'll just try to highlight them. All right, so let me start with the referred pain of the hip, referred hip joint pain. So if you remember well, what did I say? I say that from the Hinton's law that says that nerves that supplies the muscle also supplies the joint. We spoke of the femoral nerve. The femoral nerve, which is the main nerve that supplies is the what? The hip joint. That femoral nerve is going to what? Remember, in the anterior compartment, it's going to send cutaneous branches, the intermediate. Okay, I think it will be easier. Let me just do this for you to see. But yeah, it sends cutaneous branches, right? I hope I won't be long. Okay, this is sorry. Yeah. Okay. So this is your medial. The intermediate supplies this region. The medial supplies this region. They're all coming from what? From the femoral nerve. So if you have this maybe disease of the hip joint, pain can be referred to this area as well. And yeah, and also via the posterior obturator nerve that supplies the hip joint and the knee. So pain of the hip joint can also be referred to the knee. True. You know what I mean? All right, it's okay. It's okay. You know what? We're almost done. And then we go to, yeah, let me go to the posterior dislocation. Posterior dislocation, let me see if I can find something. Yeah. So this, so you're going to have what call this the sciatic nerve, right? So the sciatic nerve, it's a nerve of the sacral plexus, the main nerve of the sacral plexus, the major nerve of the body. Yes, so it originates from the ventral rami of L4 to the L4 to S3, and it composes two main nerves, the tibial nerve being the largest one, then the common perennial nerve, all those things. The cause of it may be in the gluteal region, I can say. So it originates from those ventral rami, and then it enters the greater sciatic foramina below the piriformis muscle, as you can see here. Then below the piriformis muscle, then it will be sitting or lying, right, or being sort of like I don't know, leaning on the following muscles. So first it will lean on the root of the ischium, then it will lean on the superior gemelli, the obturator antennas, inferior gemelli, or the quadratus femoris, right? And then it will descend vertically, and then here it will be at the middle aspect between the greater trochanter and the ischial tuberosity. This is your sciatic nerve. So the sciatic nerve, due to posterior dislocation of the hip joint, right? Posterior dislocation of the hip joint. You know, it's right? So let's say, for example, you are driving, you are in a car. When you are driving, usually your leg is flexed, right? Your leg is flexed, and it is flexed and it is adducted, making the head of the femur to be inside the acetabulum. So when you receive direct force, right, from the sole of the foot, it's going to kick the what? The posterior aspect of the femur, the head of the femur out of the acetabulum. You getting it right? So we are going to damage the. So let me give you the percentage, right? So listen here. Posterior dislocation occurs on 90% of population. So it is 90% common than the anterior dislocation. And in 90%, 10 to 20% they injure the sciatic nerve. And when you injure the sciatic nerve before it supplies the hamstring, you're going to find that you're going to paralyze the hamstring. You're also going to have insensation on the cutaneous skin of the leg, except the part that is supplied, the medial part that is supplied by the saphenous nerve, right? Because the saphenous nerve, remember, it's a continuation of what? It's a branch of the femoral nerve, so it won't be affecting anything. And then it's also going to cause foot drop, if you damage the sciatic nerve here. And yeah, so it pains, it sends a pain that is called sciatica, a pain that will be descending down posteriorly up to the foot. That's called the pain. That's called sciatica. Yeah, that's the posterior dislocation. I hope I'm not rushing much. Right. So that's the posterior dislocation. That's the posterior dislocation. Yeah. All right. So we are probably done with the hip joint. I think I managed to say everything that I think was important. All right. Is there any questions? Is there any questions? I hope you are not sleeping, guys. Yes, funnel.
So, like, damage to the sciatic nerve at the hip joint, does it cause paralysis? Does this is of all the muscles of the leg?
Come again. Sorry, come again.
So I'm saying damage to the sciatic nerve
Yes.
at the hip joint.
Uh-huh.
Does it cause paralysis? Damage of the sciatic nerve
Uh-huh.
at the hip joint. Does it cause paralysis of all the muscles of the leg?
All right, so when you get to the leg, right, if you understand we have the anterior compartment, the lateral compartment, the posterior compartment, right? So the anterior compartment is supplied by, that is the what? That is the deep perineal branch, right? Which is a branch of the sciatic nerve, right? The lateral portion is supplied by what?
It's lateral.
The superficial, right? And the posterior, the tibial.
Yeah.
Right, and these are all branches of the what?
Yes.
Of the sciatic nerve, right? The other nerve that is not from the sciatic nerve, that's the saphenous nerve. But the saphenous nerve, you find that that's as the saphenous nerve is about to enter the adductor hiatus, it's going to and then it's going to enter in the superficial fascia. So it has no motor supply in the leg. So I would say, yeah, it supplies. So damage to the sciatic nerve may cause paralysis of the muscles of the leg. Yeah, that's true. All of that.
Okay, thank you.